A skilled clinician can diagnose half of gastrointestinal disease before ever touching a stethoscope to the abdomen, just from the history and a careful look at the patient. That's not an exaggeration. It's the entire premise of clinical medicine, and it's exactly why GI history taking and examination is one of the highest yield, most heavily tested skill sets across USMLE, MRCP, PLAB, AMC, and MBBS clinical exams. Every symptom a patient describes, where the pain sits, what color the vomit is, whether the stool floats, is actually a clue rooted in real physiology. Nerve pathways laid down in the embryo, biochemistry, portal blood flow, peritoneal irritation. Examiners don't just want you to recognize a sign, they want you to explain why it happens. In this video, we're going to build that reasoning from the ground up, starting with how abdominal pain is actually wired into the nervous system, moving through bleeding patterns, red flags, and the full structured abdominal exam, and finishing with the eponymous signs that show up again and again in exam vignettes. By the end, you won't just memorize a list of signs, you'll be able to construct the diagnosis the way an experienced clinician actually does, symptom by symptom in real time. Here's the single mental model that should sit behind every GI question you ever answer. Anatomical fact leads to symptom, symptom leads to clinical sign, and clinical sign leads to diagnosis. Examiners do not reward rote memorization. They reward integration. A well-taken history and a systematic physical exam can localize pathology to a specific organ and even a specific segment of bowel before a single blood test or scan is ordered. Think about what that actually means in practice. If you know that the ampulla of Vater is the anatomical point where bile enters the gut, then bile-stained vomiting immediately tells you the obstruction must be below that point. That's an anatomical fact converting directly into diagnostic reasoning. If you know that the gallbladder becomes non-distensible and fibrotic after years of gallstone disease, then a palpable, painless gallbladder in a jaundiced patient immediately points away from stones and toward malignancy. This four-step chain, fact, symptom, sign, diagnosis, is the actual skeleton this entire video is built around. And once you start applying it consciously, GI vignettes stop feeling like memorization and start feeling like solving a puzzle with a defined logic. Abdominal pain location is not random. It's a direct readout of embryology, and this single concept unlocks an enormous number of exam questions. The gut develops from 3 embryonic segments, each with its own nerve supply, and visceral pain from each segment refers to a predictable surface location. 4 gut structures, the stomach, proximal duodenum, liver, gallbladder, pancreas, and spleen, send sensory fibers into the spinal cord at levels T5 through T9, so foregut pain is felt in the epigastrium. Midgut structures, distal duodenum through the mid-transverse colon, including the appendix and small bowel, enter at T9 through T11, producing classic periumbilical pain. Hindgut structures, distal transverse colon through the rectum, enter at T11 through L1, referring pain to the suprapubic or hypogastric region. The single most famous application of this is appendicitis. Early appendiceal inflammation is a midgut visceral signal, so it presents as vague, poorly localized periumbilical pain. Only once the inflamed appendix irritates the overlying parietal peritoneum, which has somatic, precisely localizing innervation, does the pain migrate and sharpen at McBurney's point in the right iliac fossa. This visceral to somatic migration is one of the most universally tested concepts in all of clinical medicine. SOCRATES, site, onset, character, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity, is the framework every clinician uses to interrogate abdominal pain, and 3 of its components are exam gold. Character alone often gives you the diagnosis. Colicky pain that waxes and wanes signals a hollow viscus trying to push contents past an obstruction. Think biliary colic or renal colic. Constant, severe, boring pain that drills straight through to the back is the signature of pancreatitis. Burning epigastric pain points to mucosal irritation from peptic ulcer disease or GERD. Radiation patterns are equally specific. Biliary pain refers to the right scapula because of shared phrenic nerve pathways. Pancreatic pain radiates straight through to the back, and renal colic classically travels loin to groin as the stone migrates down the ureter. Timing matters more than most students realize. Biliary colic resolving within 6 hours is simple colic, but pain persisting beyond 6 hours suggests a complication like cholecystitis or pancreatitis has developed. And exacerbating factors complete the picture. Pain that worsens with eating suggests either mesenteric ischemia, where blood can't meet the demand of digestion, or biliary colic, where cholecystokinin triggers gallbladder contraction against an obstructed duct, while pain relieved by eating is the classic signature of a duodenal ulcer. Dysphagia and vomiting both follow clean diagnostic algorithms once you ask the right follow-up questions. For dysphagia, the pattern is everything. Progressive difficulty that starts with solids and later includes liquids points to a mechanical stricture, most worryingly esophageal carcinoma. Difficulty with both solids and liquids right from the start points instead to a motility disorder, achalasia, diffuse esophageal spasm, or scleroderma-related dysmotility. Intermittent dysphagia points to a structural but non-progressive lesion, an esophageal web, a Schatzky ring, or eosinophilic esophagitis, increasingly common and often missed. For vomiting, the content tells the obstruction's location with remarkable precision. Bile-stained vomit means the obstruction sits distal to the ampulla of Vater, since bile has to be able to reflux upward into the stomach. Vomiting of undigested food eaten hours earlier suggests gastric outlet obstruction, or gastroparesis, where the stomach simply isn't emptying. Fecalant vomiting is an ominous sign of distal bowel obstruction with bacterial overgrowth that has progressed far enough to produce a foul, stool-like vomitus. And projectile, non-bilious vomiting in a neonate after feeds is the textbook description of pyloric stenosis, a presentation so classic it appears almost unchanged across every major board exam. GI bleeding presentations are essentially a map of how far blood has traveled and how much time it had to be chemically altered along the way. From the upper GI segment, hematemesis presents as either fresh red blood, signaling a brisk, active bleed from varices, a Mallory-Weiss tear, or a severe ulcer eroding into a vessel, or coffee ground vomitus, where gastric acid has partially digested the blood, implying a slower or older bleed. As blood travels through the small bowel and right colon, it gets converted by bacterial degradation into melena, black, tarry, foul-smelling stool that requires 50 to 100 milliliters of blood and several hours of transit time to fully develop. Here's the crucial exam trap. Melena isn't exclusively an upper GI sign. A right-sided colonic bleed with sufficiently slow transit can also produce melena, a distinction examiners love to test. Finally, in the lower GI segment, hematochezia appears as either blood mixed throughout the stool, suggesting a more proximal colonic source like diverticular disease or cancer, or blood simply coating the stool or appearing on wiping, which points toward an anorectal source like hemorrhoids or a fissure. Every GI history needs a built-in alarm system, and the alarm pathway is the framework used across UK and international exam systems to trigger urgent investigation. The letters stand for anemia, loss of weight exceeding 5% over 6 to 12 months, anorexia, recent onset of progressive symptoms, and melena or hematemesis, with dysphagia often added as a sixth red flag. Any one of these in a patient with dyspepsia mandates urgent endoscopy rather than empirical treatment. Jaundice has its own discriminator pattern. Painful jaundice with fever points to choledicholithiasis progressing to ascending cholangitis, while painless, progressive jaundice accompanied by weight loss is the classic presentation of pancreatic carcinoma, Courvoisier's law in action. And a change in bowel habit lasting more than 4 to 6 weeks, especially in a patient over 50, becomes a genuine emergency when paired with rectal bleeding or iron deficiency anemia. Together, these findings trigger the urgent colorectal cancer referral pathway, sometimes called the 2-week wait pathway in UK practice. Recognizing these clusters instantly, rather than treating each symptom in isolation, is exactly what separates a safe clinician from one who misses a cancer diagnosis. Upper GI pathology clusters into a handful of patterns that reward precise history taking. In peptic ulcer disease, the food-pain relationship is diagnostic gold. Gastric ulcer pain worsens with eating, while duodenal ulcer pain is relieved by eating, and each ulcer type has its own feared complication. Gastric ulcers can perforate, producing sudden, severe pain with a rigid, board-like abdomen from generalized peritonitis. Duodenal ulcers, through repeated scarring, can progressively narrow the gastric outlet, producing a succussion splash and early satiety from retained gastric contents. Zollinger-Ellison syndrome should enter your differential whenever ulcers are recurrent, multiple, or accompanied by diarrhea. It's mechanistically linked to a gastrin-secreting tumor, a gastrinoma, and is classically associated with MEN1 syndrome. On the esophageal side, GERD presents with retrosternal burning that's worse lying flat, relieved by antacids, and often accompanied by a chronic cough from laryngopharyngeal reflux irritating the airway. Achalasia, in contrast, presents with progressive dysphagia to both solids and liquids from the very onset, along with regurgitation of undigested food. And the bird's beak narrowing seen on barium swallow is the radiological signature every exam expects you to recognize instantly. Biliary disease follows a clear severity ladder, and recognizing where a patient sits on it is a frequently tested skill. Simple biliary colic causes colicky right upper quadrant pain lasting less than 6 hours that resolves spontaneously as the stone shifts position. When pain becomes constant and is joined by fever and a positive Murphy sign, the diagnosis has escalated to acute cholecystitis. Climb one rung higher and Charcot's triad, fever, jaundice, and right upper quadrant pain, signals ascending cholangitis, a bacterial infection of the biliary tree. Add hypotension and confusion to that triad, and you have Reynolds pentad, a marker of severe biliary sepsis, requiring emergency decompression, not just antibiotics. Acute pancreatitis sits alongside this ladder with its own signature: severe, constant epigastric pain radiating straight through to the back, classically relieved by sitting forward, a posture that reduces tension on the inflamed retroperitoneal gland. This entire hepatobiliary and pancreatic cluster rewards a clinician who can recognize escalation in real time, colic that doesn't resolve within hours, or a triad that gains 2 more features is not a subtle change. It's a different diagnosis entirely, often demanding urgent intervention. Crohn's disease and ulcerative colitis present with overlapping symptoms but completely different anatomical behavior, and knowing both the differences and the shared features is essential. Crohn's disease can affect any part of the GI tract, from mouth to anus, characteristically with skip lesions, patches of disease separated by healthy bowel, transmural inflammation that cuts through the full bowel wall, and a tendency towards strictures, obstruction, aphthous mouth ulcers, and perianal fistulae or abscesses. Ulcerative colitis, by contrast, is confined strictly to the colon, beginning at the rectum and spreading proximally in an unbroken, continuous pattern, with inflammation limited to the mucosa producing its hallmark symptom, bloody diarrhea with mucus. The two diseases share an important set of extraintestinal manifestations that are extremely high yield across every major exam. Erythema nodosum, pyoderma gangrenosum, uveitis or episcleritis, and seronegative arthropathy with sacroiliitis can appear in either condition. But some associations are disease-specific. Ulcerative colitis carries a markedly higher association with primary sclerosing cholangitis and a real risk of toxic megacolon, while Crohn's disease is the one more likely to produce fistulizing complications requiring surgical input. A GI examination is only as good as its structure, and the sequence, inspect, palpate, percuss, auscultate, is non-negotiable on every exam. Before any of that begins, positioning matters more than students expect. The patient must lie supine, with arms relaxed by their sides and the head supported by a single pillow. because a tensed abdominal wall will mask real findings underneath it, a technical error that gets heavily penalized in OSCE-style stations. On inspection, watch the patient's demeanor before you even touch them. Someone lying perfectly still is protecting an inflamed peritoneum, while a patient writhing and unable to settle is far more consistent with colic. Look specifically for the 5 F's of abdominal distension: fat, fluid, flatus, feces, and fetus. Palpation proceeds in 9 regions, light first and then deep, always assessing for guarding before deliberately testing for rebound tenderness. Percussion maps liver and spleen span and is the key technique for detecting ascites through shifting dullness. And auscultation has its own often missed rule. Bowel sounds must be listened for 30 to 60 full seconds before you're allowed to declare them absent. A premature declaration is one of the most commonly flagged errors in clinical exams. Chronic liver disease writes its signature all over the body, well outside the abdomen, and examiners expect you to actively go looking for it rather than waiting for it to be obvious. Starting at the eyes, scleral icterus is best appreciated in natural daylight rather than under artificial ward lighting. Fador hepaticus, a sweet, musty breath odor, signals that ammonia and other nitrogenous byproducts are bypassing liver metabolism, a marker of hepatic encephalopathy. Moving to the hands, palmar erythema reflects increased peripheral blood flow from altered estrogen metabolism. Asterixis is the flapping tremor elicited by asking the patient to dorsiflex their wrists with arms extended, another encephalopathy marker. And leukonychia, whitening of the nail bed, reflects hypoalbuminemia from impaired hepatic protein synthesis. On the chest, spider nevi become pathological once there are more than 5, characteristically distributed in a superior vena cava pattern and distinguished from normal vessels by blanching centrally and refilling from the center outward when pressed. Gynecomastia reflects the same impaired estrogen clearance seen in palmar erythema. And on the abdomen, caput medusae, recanalized paraumbilical veins from portal hypertension, has blood flowing away from the umbilicus, the opposite direction from the abdominal wall veins seen in inferior vena cava obstruction, a classic discriminating point examiners test directly. 2 physical exam techniques deserve special attention because of how mechanistically rich they are. Shifting dullness works on a simple principle. Acidic fluid settles into the dependent flanks under gravity, producing dullness to percussion there, while bowel gas floats centrally, producing resonance in the midline. When you roll the patient onto their side and wait briefly before repercussing, the fluid redistributes, and that dull to resonant border shifts with it, confirming free intraperitoneal fluid rather than, say, a large ovarian cyst or bladder distension, which wouldn't shift. Distinguishing an enlarged spleen from an enlarged kidney on palpation comes down to 4 features. The spleen has a palpable notch, moves down with respiration, is dull to percussion, and cannot be bimanually balloted, while the kidney is ballotable between 2 hands, sounds resonant because of overlying bowel, and barely moves with breathing. And Murphy's sign has a specific mechanical explanation worth remembering. Your fingers hook just under the right costal margin at the gallbladder point, and as the patient takes a deep breath, an inflamed gallbladder descends onto your fingers and causes them to catch their breath. That breath-catching response, not just pain, is what makes the sign truly positive. Board exams are obsessed with eponymous signs, and building a mental flashcard deck of these is one of the highest yield things you can do before any GI-focused exam. Courvoisier's law states that a painless, palpable gallbladder in a jaundiced patient points away from gallstones and toward pancreatic malignancy, because chronic stone disease leaves a fibrotic, non-distensible gallbladder that simply can't enlarge, while a tumor obstructing the bile duct allows the previously healthy gallbladder to distend freely. Virchow's node, also called Troisier's sign, is left supraclavicular lymphadenopathy signaling metastatic abdominal malignancy, classically gastric cancer reaching the thoracic duct. Cullen's sign, periumbilical bruising, and Gray-Turner's sign, flank bruising, both point to severe necrotizing hemorrhagic pancreatitis as blood tracks along fascial planes from the retroperitoneum. Kerr's sign is referred pain at the tip of the left shoulder from diaphragmatic irritation, classically seen with splenic rupture, another example of the phrenic nerve connecting an abdominal organ to a distant referral site. And in suspected appendicitis, Rovsing's sign, pain in the right iliac fossa when you palpate the left, demonstrates peritoneal irritation transmitted across the abdomen, while the psoas and obturator signs specifically suggest a retrocecal or pelvic appendix irritating those respective muscles.
Let's bring everything in this video together with one worked example, because this is exactly how a real exam vignette is constructed. The symptom: a patient is vomiting undigested food hours after eating. The anatomical fact: that vomitus contains no bile, which tells you the obstruction must sit proximal to the ampulla of Vater, because if it were distal, bile would have refluxed upward into the stomach and appeared in the vomit. The clinical sign: on examination, you elicit a succussion splash more than 4 hours after the patient's last meal, confirming that fluid is sitting retained in the stomach rather than passing normally. Put those three pieces together, and the diagnosis writes itself: gastric outlet obstruction, most often caused by chronic duodenal ulcer scarring narrowing the pylorus over time. This is the entire point of everything we've covered. Mastery in GI medicine isn't about memorizing isolated lists of signs and syndromes. It's about being able to link an embryological or anatomical fact to a symptom the patient reports, to a sign you elicit on examination, into one single unified diagnostic picture. Build that habit, and GI vignettes on any board exam stop being a memory test and become a reasoning exercise you're already equipped to win.